Okay, Headley Court, I'm sure a lot of you have heard about it and the wonderful things it does, but I want to just introduce you into our actual facilities and talking about the capability we actually have as a military unit. This is actually Headley Court that, like most people will have seen. This is the officers' mess, lovely old stately home, given to us after the war, basically for rehabilitation, firstly of aircrew, but now it's of all ranks and all services. If you took that away and look behind it, you'll find we have a huge mishmash of buildings which have evolved over the years and definitely evolved an awful lot in the last 10 to 15 years with our prolonged conflict. That's the history of it. It was originally built by the Cunliffe family and has a history being used by the Canadians in the Second World War, and then it was actually donated in trust. The mission of Headley Court, basically it's a consultant-led service, and it's in support of operations, so this is sometimes something that doesn't come across. It's basically there to support operations and to maximise what we call the moral and physical components. Physical component, easy to define. Your moral component, though, is when you're looking at keeping a fighting force active, you really need to also give them confidence that if they're injured, they will be well looked after. And this is part of the moral component of the fighting force. So these are the tasks we actually have. We have what we call role 1 to 4 treatment. Role 1 is the primary care right on the front line and the life and limb saving initial treatment. It goes through role 2 and role 3 where we have some surgical ability and comes into role 4, which is the UK based service. So you sometimes hear it referred to as a role 4 service. We force generate for ops, so I'll talk about force generation a little bit. I'm going to skip over them because it's not really, I think, what is translatable to civilian practice quite so much. But force generation basically is those people who are injured who we can get back to full military service and generate more people basically to go out on operations. We also provide specialist clinical opinions to occupational health, so anyone who is injured, we provide the opinions as to whether they are likely to get back to full fitness. It's a training environment as well for those of us who deploy on operations. We have to keep up our skills, so we train in amongst the clinical areas. We do quite a lot of research. We've got the Academic Department of Military Rehabilitation within Headley Court, and we contribute to setting the standards for clinical activity across the Defence Medical Rehabilitation Programme. So this is all of rehabilitation out in and outside of Headley Court itself. So the big thing we do, and I think this is where we most align to aspire, how we most align to aspire and to treat trust, is we look at providing the highest level of group and individual therapy. And that group and individual therapy is very exercise-based through a beast we call the exercise rehabilitation instructor. And for anyone who's not been involved in the military, these are highly qualified PTIs, physical training instructors, who have done an additional 6-month course, which is a course which takes them through treating the injured person. And so they will assess and treat the injured person. And we're actually, I think this is a big part of it, we're actually aiming to maximise functional ability. So we want to get the person back to the best they can possibly get to. And that doesn't matter whether they're remaining in the military or going out of the military. And I think this is something we fall short of. I worked as an NHS physio before being a military physio. I think this is something we can pass on and translate through NHS care, to start to look at aiming at function versus just where that person ends up, whether they can be cared for at home or need to be within a hospital environment. It's maximising function, getting that person the best it can be. So that doesn't come out very well, but the Defence Medical Rehabilitation Programme, you've got Headley Court itself, and that gets a lot of publicity. But we have actually got, through primary health care, we've also got the primary care rehab facilities. So that's generally a physiotherapist and ERI, exercise rehabilitation instructor, and we work as what you would see as an outpatient physiotherapy department. We've also got regional rehab units, which is a step up from the primary care rehab facility. They have sports and exercise medicine specialist doctors, whether that's a consultant or a GP with special interests. They have the ability to get people scanned, so enhanced imaging, and also ability to put people through a slight fast track system to actually get surgery. In conjunction, we all work together to deliver the Defence Medical Rehabilitation Plan. And not all rehab ends up, or even of our severely injured patients, ends up in Headley Court. We can only keep them at Headley Court for a certain amount of time before they start to become quite institutionalised. So what we will do is keep them for a set amount of time, depending on the injury and the amount of nursing care they need. If they don't need any nursing care, we may discharge them home to bring them back at a later date. But that rehab can then carry on. The regional rehab unit is also a residential unit, or can be a residential unit, usually has up to 30, some of them 45 beds, and will take patients for a 3-week course. PCRS, as I said, have physio and ERI. We can keep that treatment, which has been started in Headley Court, going throughout the whole of the pathway, closer to the patient's home, and while the patient is reintegrating into society, but then they could be brought back to us in order to Headley Court in order for that treatment to be progressed. These are the methods of entry. So we get a lot of publicity about our battle-injured casualties as well. We get patients coming in with musculoskeletal injuries. So through training, through sport, all sorts of things, just normal daily life. We have quite a high proportion of injuries, quite a high proportion of what goes into primary care and musculoskeletal injuries. Some of those might not get better through the PCRF and RRU, and they may come into Headley Court because that has a more specialist service. We also get patients in from the NHS. Our girls and boys are also members of society. They drive around in cars, they play sport, they get assaulted like anyone else in society, and also sometimes just are unfortunate enough to have some neurological insults which are due to medical conditions, etc. So what do we offer at Headley? We have a number of different groups, and I'm sure you'll remember from Chessington there, we generally sort of split people up into groups. It's normally, for the fourth generation, it's lower limbs, they're mainly musculoskeletal injuries, so lower limbs, spines, that's not our spinal cord injuries, specialists, they're normally upper limb, and we have medicals, I'll go through that in a second. We have neurological group, and we have 3 complex trauma groups. And I think this is important, that it is consultant-led. Yes, it's a consultant-led service, but the patient is very much at the centre of that service. And it should be, the programme should be individually tailored to that patient. There's a whole load of people who then have some input at different times, and we will step in and out, mainly led by the ERI, but the rest of us will step in and out. And we will, whoever needs to sit in, will sit in clinics and make sure we have a very multidisciplinary team approach. So this is one of the pools. We actually have 2 pools at Headley Court, and as I said, the patient is at the centre of the care. It was quite interesting. I was at a blast injuries study networking earlier on this week, and one of the things one of the surgeons said, which is something that really sort of started to make me think, is having looked at hip injuries, because a lot of his patients, having fixed the hip, they should have been able to get back to their previous level of mobility, and a lot of them hadn't. And when he started to ask them what was important to them and what were the barriers to them actually getting back to full fitness, one of the things that came out as absolutely striking is that patient was afraid of falling. They were actually more afraid of falling than they were afraid of death. And that starts to bring out that actually what we think as health professionals is important to the patient may not be what's actually important to the patient. And so putting the patient front and centre is very, 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 very important to us. It's done through group therapy, through a graded exercise programme. So the ERI will step up or scale down the exercises depending on what the patient can actually achieve themselves. And we maintain a military ethos, and what I mean by that is it's 8 hours a day generally. For each patient, 8 hours a day of therapy, of doing something. We expect them to be up in the morning. We expect them to turn up for a parade. We expect them to be dressed. We expect them to be shaved. Very different from being in a hospital environment. And that's the girls as well, shaved. There's 12 to 15 patients per group. So they also get into, we're dealing with a group of young, previously very fit patients who have very few comorbidities. And most of them are intensely competitive. You stick them in a group environment and they start to compete against each other, and that actually starts to improve, one, their mood, but also the speed at which they actually start to recover. And I think probably through your Aspire side of things, as soon as you stick people into a competitive environment, you suddenly start going beyond the one-to-one achievements you get in a one-to-one treatment. Those patients will be, for most of the 8 hours a day, with the ERI, so they're a key person, and they will go in and out to see the rest of the therapists. We may also do a lot of joint sessions with each other, and that's something I didn't find that much in the NHS either. It's, we used to all sit in our own little departments and pass the patient around. Actually, we get quite a lot if we work together in a very goal-orientated plan, and we actually coordinate our treatment. So Headley Court has 110 beds for patients who are normally on that fourth generation part, who are independent in activities of daily living. We have an additional 76 complex trauma beds and 20 neuro beds, so it's quite a large facility. We started, well, we used to have an admission, so a new admission and probably them coming back twice more. That's increased since we've been in Iraq and Afghanistan, due to our more complex injuries now, and it's about a 1:11 ratio, so for every one new patient we'll have 11 readmissions. And that's just an indication of the severity of injuries. We've had 370 amputees since June 2006, but over 85% of that workforce are our musculoskeletal injuries, which are not due to trauma. I'll quickly flick through these. Anyone who wants to look at them who's from the medical side of things, quite welcome to later. So we have spinal rehab. We run a couple of different groups. Some of them are more educational based. We go through some therapy-led side of things. But basically, we go from very, very early where we're just trying to get people functioning in activities of daily living, through some educational on how to cope, and actually through some therapy. We also have an ankylosing spondylitis group, and basically we work through a fixed exercise program with those. We have, lower limbs, it's fine. We have Centre for Lower Limbs, again, mainly working on the musculoskeletal side of things. I'm going to whiz past this because I think these are the more pertinent ones. We also have a Centre for Upper Limbs. It does deal with those people who have just normal musculoskeletal injuries, but in amongst this group we have those who have peripheral nerve injuries, chronic regional pain syndrome, etc. We have assistance from hand and upper limb plastic surgeons where necessary, peripheral nerve injury, people who specialise in peripheral nerve injuries, and we also have a special pain management team. The Centre for Specialist Rehabilitation also has a medicals team, and this is really those people who don't fit into the musculoskeletal side of things. You'll notice in amongst the team here, if you can read it from there, we also have those who have a mental, we may deal with those who have a mental health diagnosis alongside their musculoskeletal injuries. And we do have some mental health professionals in amongst our teams. We deal with a whole load of patients, including those with chronic fatigue in this group, with Q fever, which is one of the illnesses that people picked up in mainly Afghanistan, non-freezing cold injuries, rheumatology, and anything with medical unexplained symptoms. But as you'll see in all of these, it's a very very multidisciplinary approach with a consultant, physio, ERI, OT, social worker, recreational therapist, mental health, all of those professions working alongside each other for the benefit of the patient. So neuro rehab, again, patient very much at the centre of it. They offer a goal-driven, evidence-based service, and again, very multidisciplinary. We deal, although we've got a very young population, we do see some patients with strokes, we do have patients with brain tumours, etc. We screen patients who are coming back post-blast injury for mild traumatic brain injury, and they can either be seen as an outpatient, or if they are seen as more severe, we can then pick them up as an inpatient if necessary. The OTs do quite a lot in amongst this group, and they do a lot of the cognitive side of things. We've got quite good outcomes, or very good outcomes, from our neurological group, and 87% of which achieve independent living. And that's non-institutionalised care. complex trauma. Sorry for anyone who's a little bit squeamish, but that's what we're dealing with. Someone who ends up with maybe pelvic fractures, so we could have an ex-fix, double amputee, quite severe injuries. As I said before, we have 3 complex trauma groups. Again, it's a very multidisciplinary team. We start off in amongst this. We also put the spinal cord injuries in amongst this group, and we start off with these patients generally as far forward as the acute hospitals. The Royal Centre for Defence Medicine will have started the rehab with these, and also start socialisation of these patients. So in our CDM, we will start taking the patients out for meals, even though they're quite severely injured. We'll take them out for a pizza if they're medically fit enough with their family. And then they get used to, in quite a protected environment, having people suddenly staring at them, and sort of get used to that attention that they didn't normally get before. We have prosthetics. Blatchford's is on site with us, and we have some fantastic prosthetics. But some of our research is quite interesting on the prosthetic side of things, and I'll talk about that in a minute. So we have all singing, all dancing prosthesis, which a lot of people have heard about, and there's a lot of publicity about as to the follow-on into veteran care. These are fantastic bits of kit, but unless the rehab is there, the patients will not necessarily use them as effectively, and therefore won't get as much out of them as they would have done if they didn't have rehabilitation. And how do we know that? Well, we know 95% of our complex trauma patients are independent in activities of daily living, even the person who was that severely injured on the slide as I came into this. 90% of those are ambulant, are able to walk at community level or greater. Over 75% of the triple amputees don't even need a wheelchair, and when I first trained as a physiotherapist, which was a while ago, I was taught that double amputees used up to, there was no point in really getting them out of the wheelchair for any length of time, because they were going to use up to 3 times the energy an able-bodied person was going to use. We've actually done the studies on this, and it's actually nowhere near that high. Now, whether that's because of our better prosthetics now, which actually have microprocessors within the knees and the ankles, which takes some of that need for the extra energy out, or whether that's due to our rehabilitation, isn't quite evident from some of the literature. But a lady called Hannah Jarvis, Dr. Hannah Jarvis, has done quite a lot of research within Headley Court, and we're finding that compared to other authors which are using the same prosthetics on patients of roughly the same age and roughly the same disability, excuse me, we're actually getting much better outcomes, because the patients are actually using closer to about 1.4, double amputee about 1.4 times the energy expenditure, and not closer to that 3 times the energy expenditure that we were originally quoted. So fine. I've got a bit of a cold at the moment, if you can't hear. As I said, we go way out into the community. It's great to see people who are advocating sport for anyone who is disabled. I don't think a lot of people years ago would have ever thought a double amputee, you would see them going up a climbing wall, but we regularly in the Battleback facility put double amputees going up climbing walls We have them parachuting. Some of our patients have rode the Atlantic. They've gone across the Arctic. You know, there's all sorts of things. They achieve absolutely fantastic levels, and sometimes things that I definitely wouldn't manage to do half of the stuff that some of these patients do, because I'm just nowhere near fit enough. We also, as I said, try to integrate people very early back into society, and rather than them sitting in an institution in the hospital for a long time, we'll take people out for meals. We're very fortunate in the fact that a lot of event organisers offer us tickets, etc., so we go out for visits. And we also on site have a Medicinema, which is a fantastic facility. It's 45 seated plus 6 wheelchairs, shows all the new releases, and it's funded by the Royal British Legion, and Medicinema actually, along with all the major filmmakers, donate the films for free to be seen. So we've had Spectre recently, etc. As I said, we do a lot of research, a lot into the biomechanics side of things. I think it's very important. It's well known that that medical interventions move forward during a time of conflict. It's very, very important for us to assess those and to learn the lessons from conflict. So it's great we're getting all the attention now because we're just coming out of Iraq and Afghanistan, but what we don't need to do is forget those lessons and start to have to relearn them during the next conflict. And hopefully a lot of those lessons and a lot of this research starts to push out into civilian life and civilian practice. We have a lot of collaborators on the research side of things. The future, we're going to, I'm sure everyone's heard the announcements for the Defence National Rehabilitation Centre. This is at Stamford Hall, near Leicester, well, near Loughborough. It's a purpose-built location in the proximity of, it's close proximity to the Royal Centre for Defence Medicine, which is the QE Hospital in Birmingham, and our headquarters for the Defence Medical Services. And what it will allow us to do, because Headley Court is quite a mishmash at the moment, is to put those specialities next to each other, because we can purpose build it, put those specialities next to each other so we can share expertise with individual patients. Thank you.